and now Bhalla sir would be talking about glaucoma trials and studies in favor of role of ocular perfusion pressure. So we have seen in these studies that definitely as the vascular theory is there, ocular perfusion pressure plays a role in the pathogenesis of glaucoma. Whenever we basically propose a study, it has to be validated with the relevant patients and what we can do in our clinical practice, which can basically help the patient to decrease the progression of glaucoma. So sir would be talking about the various trials and studies conducted for this.
Thank you. After the beautifully explained concept of ocular perfusion pressure by Dr. Kiran Bhanot, I'll like to give the evidence. The various trials and studies have been conducted which have favored the role of ocular perfusion pressure in the pathogenesis of glaucoma. So what actually is evidence-based medicine? Previously, the medicine was considered as art, but use of scientific methodology and statistical analysis has led us to scientific way of practicing medicine. In 1990, medicine resident Dr. Jordan Goat introduced a new concept called scientific medicine, which was later on changed to evidence-based medicine. And these are the various pillars of evidence-based medicine, starting from case control studies to randomized control trials. So all these lead us to the concept of evidence-based medicine. And despite extensive research over many years, the causal events leading to OAG are still not very well understood. And besides intraocular pressure, other causes are also being looked into and researched into. And these are the various trials: OHTS, EMGT, CNTGS, Advanced Glaucoma Intervention Study, and CISTES all have stressed on the role of ocular perfusion pressure in glaucoma. But are these questions abstract? A recent meta-analysis of all the medical literature suggested that sufficient evidence exists to warrant a randomized clinical trial to answer them. So, do we have adequate evidence to justify routine assessment of ocular perfusion pressure in all our glaucoma patients? This I already stressed on. The World Glaucoma Association 6 consensus publication have said that there is a definite role of ocular perfusion pressure in not only development of glaucoma, but also progression of glaucoma after the target intraocular pressure is achieved. Baltimore Eye Survey, EGNA Newmark Study, Pro-October, Los Angeles Latino Eye Study, Barbados Eye Study, all have told us that diastolic perfusion pressure is more important. Los Angeles Latino Eye Study said that if the diastolic perfusion pressure is less than 40, the glaucoma risk increases almost 1.9 fold. And Baltimore Eye Survey said that if the diastolic perfusion pressure is still lower, that is less than 30, the glaucoma risk increases by 6 fold. So there are evidence that OPP contributes to glaucoma is favored not only by cross-sectional but also by longitudinal studies. So we all know what are cross-sectional and longitudinal studies. Incidence studies are the most valuable to determine risk factors because they are longitudinal in their design and they provide direct measure of the true risk of developing new disease over a time period. So EMGT was the first randomized clinical trial to document effectiveness of treatment in reducing progression in patients with OAG, and EMGT suggested a potential role for vascular factor on progression given the positive association with low systolic perfusion pressure, low systolic blood pressure, and CVS disease history. Baltimore Eye Survey was a population-based cross-sectional prevalence survey, and they found that less than 30 millimeter mercury of diastolic perfusion pressure increases the glaucoma risk by 6-fold. EGNA Newmark study was done to basically to study the impact of vascular risk factors on the prevalence of POAG. It was a population-based cross-sectional study, and they found that there was a correlation between IOP and BP, which was statistically significant for both systolic and diastolic pressure. The EGNA Newmark study found correlation between systolic blood pressure and higher BP that is unrelated to age. And they found that the low diastolic perfusion pressure is a very important risk factor for POAG. Pro-October study was another survey of ocular disease prevalence and specific to nearly 5,000 Latino individuals, and they found that there was a fourfold increase in OAG among subjects with a diastolic perfusion pressure less than 50 millimeter of mercury compared with those who had a higher diastolic perfusion pressure. Los Angeles Latino Eye Study was again a population-based cross-sectional study done on more than 6,000 patients, and what they found was that low perfusion pressure, high systolic blood pressure and mean blood pressure all are associated with higher prevalence of open angle glaucoma. There was a Thessaloniki eye study which was done to find association of open angle glaucoma with perfusion pressure status, and what they again found that there was an association of borderline significance between low diastolic perfusion pressure and POAG, and low diastolic perfusion pressure may be associated with increased risk of POAG, and there was no association between DOPP and pseudo-exfoliation glaucoma. Barbados eye study was a longitudinal study, and why it was done in patients of frequent descent. Reason was a frequent descent population has earlier onset of glaucoma, they have faster progression of glaucoma, and they also develop more severe visual field loss. And what they concluded was that lower ocular perfusion pressure were associated with increased open angle glaucoma, and the relative risk for lower systolic perfusion pressure, diastolic perfusion pressure and mean perfusion pressure were all statistically significant. Blue Mountain Eye Study was done in cohort study. It was a cohort study done in urban Australian population, and what they found was that eyes with narrower retinal arteriolar and venular caliber at baseline were more likely to develop OAG. So hypothesis was that due to decreased oxygen demand after loss of retinal ganglion cell. Then Canadian glaucoma study was done, and what they found was that there was 4 independent predictive factors for glaucomatous field progression. These were higher baseline age, higher mean baseline intraocular pressure, and female sex. And then this was another study done in Japan, Tajimi study, and what they found was that the most of POAG patient, almost 92% of the POAG patients diagnosed had IOP within the normal range. IOP was still identified as a significant risk factor for POAG, and they also found association of lower perfusion pressure. Leuven eye study was done in 2016, and they again found that the POAG patients presented with higher systolic and diastolic blood pressure when compared to healthier individuals. Leuven eye study concluded that it created a vast database to help find which vascular related parameter can be used to determine the extent of the disease, and which may accurately be integrated in risk stratification models. So, and then this another study done in China, which was named as Beijing Eye Study, Handan Eye Study, and they also found that there was a trend of increased risk of glaucoma with lower minimal diastolic perfusion pressure, lower minimal systolic perfusion pressure, and lower minimal average mean ocular perfusion pressure. Indian study was done. This is Chennai glaucoma study, and it was what they concluded was prevalence of glaucoma was more in urban population. There was more association with increasing age and high baseline IOP, and but they did not find any association with myopia and hypertension. Arvind eye study was done, and they found that although there was no difference in OAG between hypertensives and non-hypertensives, but there was more OAG in patients on antihypertensive therapy. Rotterdam study was a prospective population-based study, and what they found was that there is definite association between low diastolic perfusion pressure and prevalence of OAG. So association between low diastolic perfusion pressure and prevalence of OAG has been found in studies like Baltimore, Agna Newmark, Proyoctober, Barbados Eye Study, and relationship between systolic perfusion pressure and prevalence of OAG is less consistent. Only Blue Mountain Eye Study and Barbados Eye Study found association between systolic perfusion pressure and prevalence of OAG. So significant association between BP and OAG has been demonstrated by EGNA Newmark, Rotterdam and Blue Mountain eye study, whereas Barbados eye study, EMGT and Proactover found no association between BP and OAG. So there is conclusion which can be derived from population-based epidemiological studies. While a positive association exists between BP and intraocular pressure, similar link between hypertension and OAG is not very well established. Low ocular perfusion pressure, particularly low diastolic perfusion pressure, is significantly related to OAG. OAG is a multifactorial disease that develops from interaction of genetic and non-genetic factors, and perfusion pressure and vascular factors are likely involved in this interaction. An underlying factor of impaired vascular autoregulation may lead to poor perfusion in OAG. Virtual laboratories have been established by Dr. Harris. It is known as Alan Harris mathematical model, where also they have demonstrated mathematically how perfusion pressure is important. Experimental studies had been done. Now we have OCTA, where they have demonstrated a reduced disc flow index and vessel density in glaucoma, and this has been demonstrated in various studies which I'm not going to enumerate. So many key research questions still remain. At night, IOP increases, whereas blood pressure falls. Could nighttime perfusion pressure be a predictor for glaucoma risk, as was explained by Dr. Kiran? Might systemic antihypertensive treatment affect the risk of developing the disease and progression? If so, could the dosing of these medications be adjusted to reduce the risk of progression? Only time will tell whether the results of these landmark studies and trials are leading us to a correct path, or it is a case of barking up a wrong tree. Now, with that, I finish this talk on trials and